Thank you. And so we'll proceed with 4 more cases, highlighting more of the relapse refractory group of patients. So let's meet Darrell. He's a married, retired store manager. He was 69 at diagnosis back in November of 2014. He underwent VRD induction therapy, followed by an autologous stem cell transplant and 2 years of lenalidomide maintenance. He had standard cytogenetic abnormalities with translocation of 1114, but by October of 2017, he developed leg pain. He underwent a skeletal survey that showed new lesions, particularly in the femur and ribs, and no new genetic abnormalities by bone marrow biopsy at this relapse. So things to remember about him, looking back over prior therapies and other things in Darrell's life, he does have neuropathy, pre-existing neuropathy. He has, fortunately, no cardiac history, and he lives close to the clinic. So Carfilzomib is the second-generation proteasome inhibitor, as you saw listed in the options of therapy for patients with relapsed multiple myeloma. It is given intravenously in combination with dexamethasone or lenalidomide and dexamethasone in patients with relapsed or refractory myeloma who've received 1 to 3 prior lines of therapy. But it is also given as a single agent with relapsed disease after 1 or more lines of therapy. And so highlighting on the right-hand side of the screen are the various doses that we give. We always start with Carfilzomib, as you know, with a loading dose of 20 milligrams, not truly therapeutic, and then moving up to either a 27 milligram per meter squared dosing the second week of therapy thereon, or escalating even higher in a newer FDA indication of 56 milligrams per meter squared. So why do I highlight that, and we'll see it throughout the slides, is there is something to be aware of. The infusion rate is a little longer when you escalate the dose. So when giving 20 or 27 milligrams, it's fine to give 10-minute infusion, but if it goes higher, we do recommend it extend out to 30 minutes. This is a very active agent, and in relapse setting, there are many patients that have a lot of disease burden, and tumor lysis may develop. It works so quickly. So hydration is important and recommended when you're initiating treatment and as you escalate the dose. The problem is sometimes we flood our patients too much and they give a little too much hydration, which contribute to some shortness of breath, as a lot of people are shaking their head. And so it's important to monitor for that, but be mindful, maybe you don't have to give so much hydration. Dexamethasone is given in combination with these regimens, but it's also, even in monotherapy, recommended to avoid any infusion-related reaction that may occur during the infusion of Carfilzomib. It is recommended to give aspirin as a prophylaxis for thrombotic events, and also it can suppress blood counts. So monitoring blood counts, I always find this somewhat easy in this infusion-related, infusional drug, I should say, because patients are coming to the clinic. We can very easily monitor for toxicity and side effects. And so we know that there is increased incidence of infection, and so monitoring for that. But remember, like bortezomib, Carfilzomib is a proteasome inhibitor, and there is an increased likelihood of reactivation of shingles when giving these agents. So it is very important to give prophylaxis for patients on proteasome inhibitors. We know that there have been some associated cardiac and pulmonary issues associated with this drug, so being mindful of patients' prior history to any cardiac issues and watching for any emerging cardiac or pulmonary issue. It is helpful to monitor blood pressures closely. Sometimes we'll see that elevate, and also sometimes diuretics may be helpful in managing patients on this agent.
So as Tricia mentioned, Carfilzomib has various dosing schedules, and when you give the Carfilzomib in combination with lenalidomide and dexamethasone, this study called the ASPIRE trial showed that people stayed in remission longer, had improved progression-free survival. That was 26.3 versus 17.6 months, and they also had an improved overall survival compared to the people that didn't get the Carfilzomib. The ENDEAVOR study was a different study that just compared higher doses, that 56 milligrams per meter square dose of Carfilzomib with dexamethasone versus bortezomib dexamethasone. So again, just two infusional drugs or injection drugs. And what we saw was a doubling of the median progression-free survival, again, staying in remission longer when you had the higher dose of Carfilzomib. In a subgroup analysis, we did see a little bit of higher incidence of blood clots with the higher dose of Carfilzomib. So Tricia mentioned to use aspirin as prophylaxis for DVT if patients aren't high risk, if they've never had blood clots before, if they're not obese or have cardiac disease or surgery. So think about your patient, and that might change whether or not they're at an increased risk. But there was a trend for overall survival improvement in patients that got the higher dose 2 drugs versus the standard dose bortezomib.
This just highlights a monthly calendar for our patients on the Carfilzomib, lenalidomide, dexamethasone, KRD regimen. And as you can see, Carfilzomib is given day 1, 2, 8, 9, 15, 16, so 3 weeks on, a week off. The dexamethasone is given 40 milligrams once a week, even on the week off of Carfilzomib. Now, you may, this highlights 40 given once a week. But some practices may actually split that dose and give 20 on each day of the Carfilzomib, along with day 22 and 23 for the dexamethasone. Lenalidomide in the traditional fashion of 25 milligrams per meter squared, although that can get adjusted depending on renal status. I guess the other thing to highlight here, again, 20 milligrams that first week, then escalating up in this combination to 27 milligrams per meter squared. Because of those dosing, you can still give the infusion over 10 minutes. It's given for a year, but after 12 months at month 13, taking out that week 8 dosing is helpful. So it's every other week dosing along with lenalidomide, dexamethasone in the way we're giving it. And then at 18 months, even dropping out Carfilzomib from the regimen and maintaining lenalidomide dexamethasone. This, again, is another calendar. Now this is just focusing on the Carfilzomib and the dexamethasone alone, no IMID included. And this is an escalation from 20 to 56 milligrams per meter squared. And because of that, those subsequent doses are given over 30 minutes. And a similar, this is really the plan of this, unlike dropping out or stopping agent at 18 months, this is till disease progression or toxicity. But always mindful that you can get to that maintenance over time. After 12 months of going down, you could even cut out that middle dose. But the recommendation is to continue until progression or toxicity. And then, here, another calendar. I love these calendars. I always make them and never look at them, but patients love them, and it's very helpful. But so the Carfilzomib single agent, as we highlight it with the other regimens, but infusions can be higher, escalated up to that 56 milligrams per meter squared. So getting back to Darrell, after discussion of options with his wife and his daughter, who's helping in caretaking of, or involved in his care, they recommended and agreed on the KRD regimen. He underwent 3 cycles, and he achieved a very good partial remission. He's tolerating this very well. It's become part of his routine to visit his local infusion center twice a week, and doing well. So Karen is a divorce district manager. She was 57 at diagnosis back in July of 2011. She had standard risk features to her myeloma. She underwent Velcade and dexamethasone induction followed by an autologous stem cell transplant. She then underwent 2 years of lenalidomide maintenance, but by October of last year, 2017, She's now 62, and she did have a biochemical relapse. She underwent a PET CT scan and a repeat bone marrow biopsy that showed no emerging new genetic abnormalities. Due to her district managing, she travels, and she has somewhat of an unpredictable travel schedule. She has children that are raised and in college. She is a current smoker, and she does prefer some kind of flexibility with an all-oral regimen due to her work schedule. This just highlights her M spike because we did mention that biochemical progression. So you can see at diagnosis, the lower line is 0. No one should have a monoclonal protein, but she had 5 grams at diagnosis. She had a very nice response, as you can see, where after her initial treatment, auto transplant, len maintenance, went to really a complete remission. And then a slow increase in her M spike developed. So as you know from Kevin and Beth's talks and everything, we have a lot of options for therapy, but highlighting in these red boxes are the oral agents that we have options for at relapse. So lenalidomide, pomalidomide, as well as Activism. So let's talk about Activism. It is an oral proteasome inhibitor. So the other proteasome inhibitors are intravenously given or subcutaneously given. And this is indicated in combination with lenalidomide and dexamethasone. It was approved back in November of 2015. And it's for patients that have received 1 prior treatment. So it is given orally once a week for 3 weeks and then a week off, along with the traditional way we give lenalidomide, dexamethasone in that combination. So what are some of the clinical things to be aware of or think about while you have someone on this regimen? Adherence. This is an all-oral agent, so you want to pick patients that understand the schedule and will be compliant as best as we can predict. And remember, it is a proteasome inhibitor, and so antiviral prophylaxis is indicated. It works very quickly, and within a month, many people are responding and feeling well. And it is absorbed quickly as well, and as soon as you administer this, you get that call the next day, I just vomited my pill. It is so quickly absorbed that it is recommended you don't need to take that next week's dose early. No replacement, no need to repeat the dose. We know proteasome inhibitors have the ability to stun the megakaryocyte that make platelets that go out into the bloodstream, and so there's this cyclical thrombocytopenia associated with Activism, just like the other proteasome inhibitors, and that as you take that week off of treatment, you'll see the platelet count jump back up to their baseline. It does have neuropathy associated with it, and it is something to be aware of and monitor, as well as some peripheral edema has been associated with this agent.
And as Tricia mentioned, the drug regimen is FDA approved in combination with lenalidomide and dexamethasone, and we know that based on a clinical study with about 722 patients, and it was primarily in Europe, but it compared the 3 drugs, Activism, lenalidomide, and dexamethasone versus just the 2 drugs, lenalidomide and dexamethasone. In patients that took this all-oral regimen, which has a pretty quick way of working, 1.1 months you had said, there's a 35% improvement in progression-free survival. Here you can see the dosing calendar. It's only 3 pills a month, and that's really important to highlight. They can't break or chew the capsules. You have to keep them in their original packaging. So calendars are very useful to say, okay, wake up on Monday, take your dexamethasone, a couple hours later take your Activism, and then you can have a nice lunch. Remember, in this dosing, we keep dexamethasone even on the off week, so it's important to highlight in the calendar. There are 2 clinical trials that Activism, again, this is not FDA approved in maintenance therapy, but there was a phase 1/2 clinical trial of patients that had lenalidomide and dexamethasone in newly diagnosed myeloma. So again, it's approved in relapse, but we have compelling evidence that this is going to be safe and very effective in patients with newly diagnosed myeloma, and we can achieve that MRD negative status, remember, getting rid of as much protein as possible, and we have had some evidence of that in this first trial. In the second trial that's highlighted on this slide, Activism plus Lendex in 64 newly diagnosed patients, followed by twice-weekly Activism maintenance, so a little different dosing schedule. Again, not FDA approved, but there are high response rates with MRD negativity being achieved as well.
Thanks, Beth. So Karen elected to go on the IRD, or Activism, Revlimid, dexamethasone. She's tolerating it very well. She is compliant with her all oral regimen and is taking it and is on an empty stomach for more assurance of proper absorption. She is on acyclovir prophylaxis and DVT prophylaxis. She hasn't exhibited any problems with GI toxicity like nausea or diarrhea. So our fifth case is Barbara. Barbara is a divorced child psychologist. She was 62 at diagnosis in 2012. She underwent RVD, induction therapy, followed by an autologous stem cell transplant, followed by lenalidomide maintenance, continuous with no, did not stop, and also initiated pamidronate at diagnosis. But in January of this year, she had some symptomatic relapse, had a skeletal survey that showed new bone lesions where her symptom was pain. And she was discussed various options and elected to start daratumumab, pomalidomide dexamethasone, or DPD. So pomalidomide, another oral agent. It is an IMiD, the third generation IMiD, and it's indicated for patients with myeloma who have had at least 2 prior therapies, including bortezomib and an immunomodulating agent. Important thing to highlight is that patients who have had Revlimid and it may not be working anymore, pomalidomide is definitely an agent that works even in that setting. So it's important to be aware of that. It's also, they have this newer widening indication by the FDA last summer in June of last year in the combination with Dara-Pom-Dex. So it's given orally. Again, like other oral agents, it's recommended to avoid food while taking it 2 hours before and after. And again, don't crush, chew, or tamper with the capsule. I don't know who would do that, but it's important to. So what are some of the clinical pearls with patients who are taking pomalidomide? It can lower blood counts, and the blood counts can drop pretty quickly and pretty significantly. And so it is important to monitor initially. Weekly is recommended just to monitor that and adjust dosing, watching for that. It is metabolized by the liver, so monitoring liver functions is helpful. And always monitoring for response to treatment. It can work quickly, and just to be aware. There is a REMS program with all the IMiDs, just to highlight that, and it's really a program, as we all know, that provider, patient, and pharmacists all participate in to really avoid exposure of this agent or other IMiDs to fetuses. There is infection prevention that is helpful with this. Because of that low blood count, neutropenia, you can have an increased likelihood of infection. So monitoring for that, having patients notify you if they are becoming sick. And as we mentioned earlier, we highlighted a little bit in this case, their smoking can interfere with the effectiveness of this agent, efficacy of the agent. So it's for those that are patients who are smoking, it really is a good tool to say, hey, stop. This really will impact on the efficacy of this treatment potentially. It is excreted by the kidney, and again, always mindful of anyone with myeloma to really stay well hydrated and to avoid agents that might hinder or hurt the kidney, like nonsteroidal anti-inflammatories, IV contrast dyes, anything that we tend to do, some drugs that might interfere. So just to be mindful of that. This, again, is another patient calendar similar to Revlimid and dexamethasone. It's given 21 days of therapy. The recommended starting dose is 4 milligrams, with dexamethasone 40 milligrams weekly. Even on the week off of the POM list. What you see highlighted on the top of the screen is the dexamethasone dose is a little lower in patients over 75 or who are a little frailer. Because of that, incidence of infection is a little greater in patients that are over 75.
And as Tricia mentioned, our patient had opted for daratumumab, pomalidomide, and dexamethasone. And this was based on results of a study of about, 403 patients were given just the 3 drugs, and the daratumumab was the standard dose. And all of them had had prior bortezomib, not all of them, but many of them had prior bortezomib, and many of them had prior lenalidomide. And so you can see here on this slide, all of them had great response rates. But remember, the daratumumab interferes with the complete response, so that's because they might be measuring the daratumumab in the blood. It looks like a monoclonal antibody on that SPEP test, so their proteins won't always go to 0 in the blood when they're on daratumumab, but it's important to remember. The progression-free survival, again, there's only one group, but the progression-free survival was prolonged when patients were on that. And here's a similar dosing calendar for your patients, similar to what we've shown. Again, it's weekly for 8 weeks, and then it goes every other week, and then it goes monthly, and then they're essentially just on the pomalidomide maintenance, which is really nice.
Mm-hmm. And just to get back to what Beth was saying, it made me think it's an IgG antibody, and we had a patient that had an IgA myeloma and responded beautifully. And then all of a sudden, when they were on Darrell, we started to see, oh my gosh,
IgG.
mild progression or a hint of a monoclonal protein. So immunofixation to really identify what is the antibody you're seeing. So that was helpful for us because we could see that it was probably the Darrell-related measurement we were seeing. So Barbara is our went on to 4 cycles of this. She had a very good partial remission. She's tolerating it well. Just like proteasome inhibitors, monoclonal antibodies also run a higher risk of reactivation of viruses and shingles. So prophylaxis, she remains on that, acyclovir. She's on antithrombotic therapy as well as PJP, which is the new PCP, which is the fungal pneumocystis infection in immune-compromised patients. That's something I just learned. And she also is compliant with her survivorship plans and seeing her PCP and monitoring for her routine care. So our final case is James. James is married. He's a retired restaurant owner. He was 75 at diagnosis. In July of 2014, he had standard risk myeloma. He underwent Revlimid and dexamethasone induction, continuous. The reason for continuous is at his age, he did not go on to stem cell transplant. He unfortunately had evidence of relapsing in November of 2016 by some evidence of mild anemia emerging, as well as a rising M protein in his blood work. So things to be concerned for James is that he is a diabetic, and he does have some peripheral neuropathy. So he lives close to the center, and he is interested in this really cool new thing called immunotherapy.
So immuno-oncology is similar, our monoclonal antibody, daratumumab, and, patients will be so savvy, they'll come to you and say, I want immunotherapy. And so elotuzumab is an anti-SLAMF7, signaling lymphocyte family activating molecule 7. And it also enhances natural killer cell activity, which is their unique mechanism of action. This is also approved in combination with lenalidomide and dexamethasone. As an antibody, remember, they have a higher risk of shingles, so make sure your patient's taking zoster prophylaxis with acyclovir or whatever your institution recommends. And the infusion pre-meds are the important things. About 70% of the infusion reactions will be with the first dose. So most of the time, if people get through it with a slower infusion rate, you can start at the 0.5 milliliters per minute and then escalate the dose, monitoring blood counts, response to treatment, and blood sugars as well. A lot of people are on corticosteroids. They marry well and make everything better. And so Kevin had shared with us the importance of monitoring blood sugars, making sure that they have their checklist, morning versus nighttime administration, and really talking about the consistent schedule. In your little USB, we have several different publications from the Nurse Leadership Board on managing side effects as well as IMF brochures. Tricia?
Okay, and then, so James, getting back to him, he had all the therapies and options discussed, and he decided, since he was tolerating Rev-Dex fairly well, this biochemical progression, he added in elotuzumab to that regimen, and he's undergone 4 cycles. He's achieved a very good partial response to that. He's tolerating it very well. He does require some adjustment to his insulin on days of and days after his steroids, and his liver functions remain normal.
So these are just listing some of the drug regimens in development, and I won't go over all of them, but it's so nice to know that although we have 16, 17 new regimens approved since the 2000s, essentially, venetoclax is a hot one that's coming out, especially at a translocation 1114. That drug's approved in CLL. And then selinexor is also really important. I just wanted to briefly mention the Black Swan Initiative, which looks at MRD negative status. We never thought black swans could exist until we saw one, just like we never thought a cure in myeloma could exist until we now have drugs that'll get us there. So by having knowledge about the drugs and encouraging the shared decision-making for patients, again, getting them to recognize their voice is important. And again, the International Myeloma Foundation has a very cool iStop Myeloma, and this is the Icelandic group, is looking at 140,000 blood samples from all of the patients over the age of 40 and looking at patients with MGUS, smoldering myeloma, really trying to understand the backbone of what causes myeloma to progress, et cetera.